Good morning, everyone. Welcome to today's seminar, Biomechanical Considerations in Implantology. These are the contents. Coming to introduction, biomechanics is one of the most important considerations affecting the design of framework for the implant bone processes. In general, the forces which participates in both masticatory process and the parafunction must be considered in the design of the processes. These considerations act as a determining factors for the device success or the failure. Now, what is the definition of biomechanics? According to the GPT-8, it is a relationship between the biological behavior of oral structures and the physical influence of the dental restorations. Now, there are two types of biomechanics. One is a reactive biomechanic and one is a therapeutic biomechanic. So, the reactive biomechanic is a interaction of isolated biomechanical factors like the resultant force, muscle force, impact areas. So, these biomechanical factors, when combined, it produces a cumulative effect, which is known as a reactive biomechanic. And in a therapeutic biomechanic, is the clinical process of altering each biomechanical factors which reduce the cumulative response which causes the implant overload. Now, there are various loads which are applied to the dental implant like the occlusal load, passive mechanical load, perioral forces like the muscle forces or the forces from the cheek and the non-passive prosthesis forces. Now, coming to the clinical loading axis, there are basically three clinical loading axes. First is a mesiodistal, second is a faciolingual, and third is a occluso-apical. So, the process by which these three-dimensional forces are broken down into their component parts, which is basically called as a vector resolution. So, these may be used routinely in a clinical practice to enhance the implant longevity and the implant success. Now coming to the forces, there are three types of forces. The first is the compressive forces, second is the tensile forces where the objects are pulled apart, and the third one is the shear forces which causes a sliding forces onto the implant. Now forces can be signifies as a magnitude, duration, direction, type, and the magnification factors, which are known as a vector quantities. Now coming to the magnitude and direction, uh, greater the force applied, greater will be the stresses developed around the implant. So, like if the patient has a parafunctional habit, so the this magnitude of the force increases. Duration, the perioral muscles also apply a constant yet light horizontal forces onto the teeth and the implant. Like the parafunctional habit significantly increases the duration of these loads. Because of the increase in the function, the time for the constant load and the fatigue occurs in the implant component also increases. Now, what is force magnifiers? The force magnifiers may be magnitude of the force may be decreased by reducing the significance of the magnifiers of the force. So, the magnifiers of the force consist of cantilever length, offset loads, and the ground height. So, when these basically these magnifiers of the forces are indirectly proportional to the magnitude of the force. Now, coming to the position in the arch. Maximum biting forces occurs in the molar region and decreases anteriorly. So the forces are basically less in the anterior teeth and which are more in the molar region. Now, what is stress? The stress is basically the manner in which force is distributed over the surface and which is known as a mechanical stress. Uh, so the magnitude of stress is basically dependent on two variables. First is the force magnitude and second is the cross-sectional area which is a force dissipated. So coming to the force magnitude, this force of magnitude rarely uh, is controlled by the dental practitioner. The magnitude of force may be decreased by reducing the significant magnifiers of the forces. The magnifiers of the forces, as we have seen earlier, are cantilever length, offset load, and the crown height. So night guard basically decreases the nocturnal parafunction and reduces this force magnifiers. occlusal materials also decreases the impact force, and instead of giving like the overdentures, rather than giving fixed prosthesis also, fixed prosthesis can be, so basically overdentures can be removed at a night instead of giving fixed prosthesis. So instead of giving fixed prosthesis, overdentures can be given, so it can reduces the force magnifiers. Now coming to the functional cross-sectional area, it may be optimized by increasing the number of implants for a given edentulous site, and selecting the implant geometry that has been carefully designed to maximize the functional cross-sectional area. Now, what is stress and strain relationship? A load applied to the dental implant may induce deformation of the implant by the surrounding tissue. So, biological tissues may be able to interpret deformation or a manifestation thereof if they respond with the initiation of the remodeling activity. The relationship is needed between the applied force that is imposed on the implant and the surrounding tissue, which is experienced throughout the system. Now, what is impact load? So, impact load is basically when two bodies collide in a very small interval of a time, relatively large forces develop. So, such collision is described as an impact. So, higher the impact load, there will be greater risk of implant and bridge failure, which might result in the bone fracture. Um, Coming to the force delivery and the failure mechanism, it is basically the manner in which forces are applied to the implant restoration, which dictates the likelihood of the system failure. So, if force is applied some distance away from a weak link in the implant or a prosthesis, it may result into the bending, or the may result into the torsional failure, and again it results into the moment load. Now, coming to the clinical moment arm and the crestal bone loss. So, basically, a total of 6 movements may develop about the 3 clinical axes. So, such movements load induce micro rotation and stress concentration at the crest of the alveolar ridge at an implant to tissue interface, which may lead to the crestal bone loss. So clinical movement arm exists in implant dentistry are three. First is the occlusal height, second is the cantilever length, and third is the occlusal width. Coming to the occlusal height, basically occlusal height serve as a moment arm for the forces component which are directed along the facial-lingual axis as well as the mesiodistal axis. So moment of the forces along the vertical axis is basically not affected by the occlusal height because there is no effective moment arm. So offset occlusal contacts or the lateral loads, however, it will reintroduce to the significant moment arm. A lingual force component also may induce a twisting moment about the implant neck axis if applied through the cantilever length. So clinical experience suggests that distal cantilever should not extend 2.5 times the AP spread under the ideal condition. Coming to occlusal width, so wide occlusal table increases the moment arm for any offset occlusal load. Faciolingual tipping, like the rotation forces, can be significantly reduced by narrowing this occlusal table or adjusting the occlusion to provide more centric contacts. Now coming to the forces type and its influence on the impact body design. Basically there are 3 type of forces: the compressive, tensile, and the shear. So compressive is basically given by the bone, which is very strongest. Tensile is 35% weaker, shear is a 65% weaker. So basically implant is designed according to the macroscopic body and the microscopic body design. Macroscopic body design will give early loading and mature loading periods, whereas the microscopic body design gives the initial implant healing and the initial loading period. Coming to the different geometry and its effect. So implant microgeometry consists of smooth-sided cylindrical implants, which are basically subjected to the shear forces. If the implant has a smooth-sided taper taper geometry. So these type of macro geometry places a compressive load at the implant and bone interface. Tapered threaded implant causes compressive load to the bone, and if the taper is more, so there will be greater compressive load delivery. Thread geometry. Thread geometry maximizes the initial contact and it enhances the surface area. It also facilitates the dissipation of the load at the bone implant interface. Thread pitch. So maximum effective stress, basically thread pitch maximize the effective stress and it decreases with the decrease in the pitch. Implant thread shape. Basically, there are three types of thread shape: the V shape, the reverse buttress, and the square threads. According to the Kim et al., he evaluated that implant with the same number and the depth of the thread with the different thread shapes. Uh, the V shape and the reverse buttress had a similar values. Greater the coming to the greater the thread depth, greater will be the surface area for the implant. Now, uh, thread depth uh, is most in a V-shaped thread depth. So basically, as the increase in the diameter, thread depth is also increases. Coming to the crystal module design, crystal module design, like the smooth parallel sided crest has a shear stress large diameter than the outer thread diameter prevent the bacterial ingress and initial stability. It gives the initial stability. Helps in the bicortical stabilization. Maximum stresses generated by the lateral load can be dissipated by the implant in the range of 10 to 15 millimeters. Softer the bone, greater will be the length or the width. Sinus grafting and nerve repositioning to replace greater implant length is very useful. Coming to the implant width, increase in the implant width increases the functional surface area of the implant. So increase in 1 mm of the width increases the 33% of the functional surface area. Bone response to mechanical load. So basically, bone respond to the number of factors, including the systemic and the mechanical forces. Cortical and the trabecular bone, which are modified by the modeling and the remodeling, they are controlled by the mechanical environment of the strain. What is fatigue failure? So fatigue failure, continuous forces on the certain materials may result into the internal deformation, which is after a certain amount of result in the permanent deformation or a fracture. The biomaterial, like the stress level below which an implant biomaterial can be loaded indefinitely is referred as a endurance limit. Number of cycles, like the loading cycle should be reduced. Elimination of the parafunctional habit, reduction of the occlusal contacts. Coming to the implant body biomaterial related to the fracture, so there are different biomaterials like the vitreous carbon, which has a modulus of elasticity, optimal modulus of elasticity, and it has ultimate strength, which is not adequate. The ceramic material which is used, it has ultimate strength, and it has modulus of elasticity 33 times stiffer. Titanium has the closest approximation of modulus of elasticity, and it has ultimate strength when compared to the ceramic. Basically, titanium is of two types: the commercially pure titanium, and the other one which is used is the titanium 6 aluminum 4 vanadium alloy. So amongst this, titanium alloy is 4 times stronger than the commercially pure titanium. Now, implant components and their reaction of the forces. So, coming to the implant component, like the retention screws, the basically retention screw loosening may result from the following factor, like the occlusal interfaces, the design, or increasing in the crown height, or the material type which is used. So screw loosening can be decreased by a preload with a torque wrench on a screw. By tightening the screw. So this is basically done, how it's done, that first we tighten the screw, then we untighten it after a few minutes of retightening it to the required force. So basically this tightening and untightening causes a deformation at a thread interface, which forms a secure reunion. Um, and the other factor is a cement. So load over a cement retained prosthesis may cause a disruption of the cement seal, causing the movement of the prosthesis. Next is a bone implant interface. So when the implant receives an occlusal load, there is an increase in a micro strength next to the implant bone interface, which results into the increase in the bone density. Therefore, increasing in the bone implant interface density reduces the crestal bone loss. Coming to the force distribution implant prosthesis. So, in implantology, splinting is there is a phenomenon of splinting the implant. So, in a natural tooth, there is a periodontal ligament. So, all the forces which are acting onto the tooth are equally distributed. But onto the implant is basically stiffer. So, no force distribution. So, there is a no force distribution. So all the forces are concentrated at a crystal bone. Now, force distribution in the combined prosthesis. When prosthesis is of combined, like the which is a bone, the tooth supported and the implant supported. So it can be it may have some attachments. So uh, some of them are flexible and some of them are stiff. So flexible can be internal attachment, and stiff attachments can be of terminal attachments. Now, diagnostic factors in a combined prosthesis is, so internal attachment, basically internal attachment placed in a distal of the natural tooth, so which provides a differential mobility. And natural tooth cannot support that implant, they increases in the lever arm and increases the torque. Now coming to the four variants, clinical variants with the implant loading, it includes the cuspal inclination. So in cuspal inclination, when the cuspal inclination is increases in 10 degree, there is a increase, there is a 30% increase in the torque. And second is the implant inclination. So when the implant inclination is increases by 10 degree, there is a 5% increase in the torque. In horizontal implant offset, when this horizontal implant offset increases by 1 millimeter, the torque which is occurs is 15%. And in apical implant offset, when it is increased in 1 mm, the torque which is it is increased by the 5%. Now coming to the therapeutic biomechanics, when there is a decreased inclination, basically this decrease in the cuspal inclination reduces the distance between the implant, and it will it results in the line of forces. Coming to the implant position, implant head whenever placed close to the central line of the restoration, it reduces the horizontal offset. So the vertical overlap can be steep or the less steep. So less steep vertical overlap causes extreme torque, whereas this steep is less, it will cause less torque production. Now, the biomechanics and the restoration pattern. So, in posterior mandible, bone resorbs along the root inclination. Therefore, posterior mandible bone resorbs lingually. So, to overcome this problem, lingual position of the restoration along with the buccal implant placement can be done, which increases the torque. In a posterior maxilla, reactively there is a restricted maxilla, there is a sinus opening, sometimes the buccal cortical plate might get fractured, which results in the unfavorable biomechanics. So to overcome these problems, the cuspal inclination can be reduced, and head of the implant should be placed close to the center of the rotation, and the cross occlusion should be given. In anterior maxilla, aesthetically, basically the tooth are labially proclined, and sometimes it has a steep vertical overlap. So to overcome these problems, lingual horizontal stop should be given, which redirects the forces as vertical as possible. Angle abutment can be given. So to conclude this seminar, the most common complication in the implant-related reconstructions are related to the biomechanical considerations. The manifestation of the biomechanical loads on the dental implant controls the long-term health of the bone-to-implant interface. It can be summarized that a destructive cycles can develop with the moment loads, which results into the crestal bone loss. Unless the bone increases in density and the strength, the cycle continues towards the implant failure if the biomechanical environment is not corrected. These are the references. Thank you.